From the RSNA, I'm Dr. Jana Ivanidze, and this is the Radiology Imaging Cancer podcast. In this episode, we're going to talk about racial disparities in oncologic imaging and oncology more broadly. I am thrilled to have been appointed podcast host and associate editor of the new journal Radiology Imaging Cancer, and grateful for this opportunity and the mentorship and support from the editorial board and the wonderful staff at RSNA and the journal. This is my inaugural episode since I have just recently returned to work from maternity leave. My son Ronan was born March 11, 2020. Yes, the day the World Health Organization declared COVID-19 a global pandemic. I thus want to take the opportunity to introduce myself. I am an assistant professor of radiology at Weill Cornell Medicine. I was born in Kiev, Ukraine, and moved to Munich, Germany at the age of 8 when my family fled anti-Semitism in the early 90s. And by my family, I mean my mom and I. I graduated from Ludwig Maximilians University Munich School of Medicine in 2009 and got my PhD in neuroimmunology from the Technische Universität Munich in 2011. I came to the US shortly thereafter in 2011, in fact 2 weeks after my PhD defense, having matched into the Weill Cornell Radiology Residency Program. I did my radiology residency, neuroradiology fellowship, and nuclear medicine molecular imaging fellowship training at Weill Cornell, and have been on faculty since February 2018. Clinically, I do a mix of neuroradiology and nuclear medicine, molecular imaging and therapy, and my research is focused on advanced brain imaging, particularly PET-MR and novel PET tracers, dynamic PET, as well as perfusion MRI and blood-brain barrier imaging. My current clinical trials include dotatate PET-MR imaging in meningioma, FLT and F-MISO imaging in high-grade glioma, and development of multimodal biomarkers in Alzheimer's disease. We currently are at a point in time where systemic racism is increasingly recognized and is more and more widely acknowledged that it permeates every aspect of our society. While this is not a new issue, and in fact the result of centuries of oppression, recent events, including police brutality, particularly the killing of Mr. George Floyd, Ms. Breonna Taylor, Mr. Ahmaud Arbery, Mr. Rayshard Brooks, and sadly many other Black Americans, have launched a growing movement aiming to address and dismantle systemic racism in our society. A major example of systemic racism is racial disparities in access to healthcare. In this podcast episode for Radiology Imaging Cancer, I want to shine a light on research focusing on racial disparities in oncologic imaging and in oncology more broadly, and share the stories of the outstanding physician scientists doing this important work. I will be discussing this important subject with my colleagues Dr. Efren Flores from Massachusetts General Hospital, Dr. Joseph Osborne from Cornell, Dr. Ashley Prosper from University of California, Los Angeles, and Dr. Randy Miles, also from Massachusetts General Hospital.
What economic impact is COVID-19 having on radiology? Join RSNA faculty and Highland Healthcare experts for a webinar, The Economic Impact of COVID-19 in the Radiology Community, on Thursday, July 23rd at noon Central. Topics include financial implications of volume reduction, image protocol changes, cutting through the red tape, and looking to the future. Register now at rsna.org/COVID-19.
Dr. Efren Flores is an assistant professor of radiology at Massachusetts General Hospital who specializes in cardiothoracic radiology and emergency radiology. He is also an accomplished health services researcher focused on understanding health disparities to inform the development of innovative and multidisciplinary interventions to enhance health equity for underserved patient populations. His clinical experience and his personal background, he's from Puerto Rico, serve as strong foundations for his clinical research at the intersection of equity, innovation, and healthcare. He and I had the pleasure of meeting during the RSNA Clinical Trials Methodology Workshop in 2019, where not only did we have a great time, and he got to meet my son and my mom, but he also presented his innovative trial on lung cancer screening in Latino men. Dr. Flores, thank you so much for joining me today.
Good, and thank you for having me today. I really appreciate this opportunity, and absolutely a pleasure joining you this morning.
Thank you. Pleasure is all mine. So you have studied the relationships between missed care opportunities and various sociodemographic factors, including race. Could you tell us about this work and what have you learned about racial healthcare disparities in radiology, particularly oncologic imaging?
Patient engagement is a shared responsibility between the patient and the healthcare system, including radiology. Many times this responsibility is solely placed on the patient. But if we consider that patients are facing a lot of barriers to care and navigating the complex medical system, we should really try to emphasize our efforts in eliminating or mitigating some of the barriers to care. Let's take, for example, language. So we talk about patients not coming to appointments or missing appointments. We tend to use the word no-show, which places the responsibility solely on the patient. But if I think of a patient that prefers Spanish language, that missed a couple of MRI appointments for oncologic workup or follow-up, and the reminder message is in English, so they have a hard time understanding it. When is it? And they miss the appointments. And that's why we use the term missed care opportunities rather than no-show, because what we found in this work, individuals from lower socioeconomic status or individuals with limited English proficiency or underrepresented minorities tend to have a higher proportion of missed care opportunities or missed appointment. So how do we connect with the patients better? How do we receive them better when they come to the waiting area and even the reminder process? And so we have to put an additional emphasis on that part to improve the radiology experience for all our patients. And this is absolutely critical. If we think that patients are coming for radiology, the majority of patients are referred to us in a time of need when they either have an acute medical condition that needs to be further evaluated, or they have, for example, oncologic workup or disease management or monitoring of their cancer treatment. So a lot of decisions are pending based on the imaging results. They're absolutely critical that the patients get the best care, that is timely, but it also fits their needs. And that's our responsibility in radiology, is to try to engage our patients.
Absolutely.
Before they have the missed care opportunity or their missed appointment. So just giving a voice for them.
Such important work. And
yep.
So maybe for our listeners who are not as familiar with this type of research, can you tell us a little bit more about your research methodology? How do you study these research questions? And also, how can your research inform, you touched on it a little bit, but maybe tell us a little bit more about how can this research inform the development of interventions aiming to decrease racial disparities?
So it's critical for our group that we try to give a voice to those or advocate for the patient that have difficulties advocating for themselves, or give a voice to those patients that are not really connecting with the system. I think having a finger on the pulse on the community and our patient is absolutely critical to our work. For example, many patients, this work is really inspired by a conversation that I had with a patient that missed a few appointments, and I went into the MRI scanner the third time she came because I wanted to find out if she had more clinical symptoms brought her this time. And then when I spoke with her, she was a Spanish-speaking patient, couldn't understand the reminder message. And when I talked to her and she told me this, I was surprised, but also this served as an inspiration because it made me wonder how many more patients are not truly connecting with the healthcare system. And what can we do better? Just simple way. And many of our research projects, when we talk about lung screening, for example, many individuals from some of the work that I do with a colleague in psychiatry, that patients with schizophrenia or bipolar disorder, which are categorized as patients with serious mental illness, have a high smoking prevalence, but typically don't have access to the healthcare system. So what we try to do is look at it systematically, because this comes from listening sessions. So what we call the listening session become more of structure through qualitative research, where we do focus interviews to focus groups or individual interviews that are analyzed based on themes and domains. And then we use that information to also inform our research when we take larger sample or population health-based research, when we take a larger sample to see what are the socioeconomic and demographic factors that are associated with a specific barrier to care, either missed appointments to diagnostic imaging, either CT or MRI, or it could be to missed appointments to lung cancer screening, or what are some of the delays in lung screening or screening mammography, for example, which relates to oncologic care. And then we use the information that we get through systematic population health-based research. So we try to we really work hard to ensure that our results and interventions are generalizable beyond our own healthcare system.
I'm sure that it's so meaningful to those patients that are Spanish-speaking, for example, for you to come and introduce yourself to them and have a conversation with them. I'm sure that must be very inspiring.
No, absolutely. I mean, one of the things that we saw, for example, even during COVID-19, when we had the surge, you can see when we had a higher proportion of Latino patients being admitted to the intensive care unit and to the regular floor for treatment of COVID. And we had to form a Spanish language care group, which was an ad hoc group to assist the clinical team with Latino patients because as complementary to interpreter services. Mm-hmm. And once you started talking about to the patients in their own language, you could see like immediate relief in their voice and their faces. So it really is providing cultural competent care. And that's, one of the things that I think our group really tries to enhance through our research is to understand what are some of the factors where patients are getting that may result in barriers to care and really tailor the care that we provide based on that information. We found that patients with Medicare, Medicaid, and underrepresented minority, racial and ethnic minorities had higher rate of missed appointments to MRI. And based on that information, our radiology department started offering a ride-share service to patients that spontaneously express a need to cancel because of an transportation barrier because they couldn't make it to their appointment. What we saw in the initial analysis of the ride-share service is that it was benefiting the population that we found earlier to be being affected by this missed care opportunity. For example, patients with Medicaid and older patients who typically have transportation barriers in other specialties. In healthcare, we're benefiting more from this service.
I think what you're doing is so important, and I hope that many of our listeners themselves maybe will be inspired to initiate such projects locally at their site.
And one of the things that I tell people is like, but thank you for your kind words. One of the things that I tell people, because sometimes the work can be overwhelming because there's so many barriers and so many things happening all the time to all patients. So any assistance is a win for them, regardless. So it could be just as translating material, something that they were not receiving before. So if they get it now, then absolutely that's a win for them. And many small wins build up to a big win.
So this brings me actually to my next question. How did you yourself get started in this field of research? And what advice do you have for imaging scientists, especially those listening who are more junior in their career, interested in studying racial disparities?
So to me, I would say that to get started is select any area where you see your patients having difficulties accessing your care. I think the act of listening carefully to our patient, incorporating them into your understanding and also into your practice, incorporating the voice of the patients and the community is really a critical component of what we do. And that's what we try to do with our research. First, the work is very rewarding, I have to say, because we're assisting patients that typically have difficulties navigating the healthcare system, and the benefits are tremendous. There's a lot of work to be done, but I would just suggest to people to start anywhere. So any step in a positive direction is better than before. Also, really, if you feel that, alone or like that you may be having some difficulty navigating this process, please reach out to your colleagues. There are many that are interested in working in this space, not only at your institution and other specialty, but also across radiology.
It's an invitation to collaborate for all.
Absolutely. No, I've seen a lot of change in the interest in this work through the years, and I see the next generation of trainees being very interested in incorporating this component in part of, for example, their AI research or their oncologic research. So how do they make their research more accessible? And if you think about it, so we cannot have high quality care if our care is not equitable. So we have to make sure that everybody can access the care that we provide, and then we'll be able to achieve high quality care. And then also same thing applies to our research. I would encourage everybody just to look at their work through more than a diversity lens, just look at it through a health equity lens, so you can really enhance all aspects of your imaging care. So when people had a meeting about a research study with internal medicine physician, so in the near future, it will be ideal that when people discuss health equity issues, diversity and inclusion issues, then rather than ask why radiology is involved, it's like, what is radiology's contribution into this area and how we need to incorporate their voice So it's changing the narrative. So we don't see I would say like a stranger at the table. We're not stranger. We really care about our patients, and that's very clear. And
part of the
absolutely. We're an integral part, and we're really focused on patient-centered care. That would be my advice to everybody, is just to get involved anywhere that you can start. And if you feel alone, or like if you feel need, or like anytime that you want to discuss, there are many of us that are always available and happy to help out with the process and just think through ideas or anything that we can do.
Listeners, thank you so much. Dr. Efren Flores leading the way in patient-centered research and racial disparities research. I learned so much from this conversation, especially every imaging study is a patient encounter. I think that's something that we should all remind ourselves of. And thank you so much for taking the time to speak with me today.
No, thank you. It was definitely my pleasure and honor to be here. And anything that I can do for you or the RSNA is always an honor for me. So thank you for the opportunity to having me today.
Dr. Joseph Osborne is professor of radiology at Weill Cornell and my division chief and mentor in molecular imaging and therapy. He's the director of the MI4, Laboratory for Molecular Imaging Innovation and Inclusion, where as a physician scientist, he strives to promote practical, value-added molecular imaging and reduce healthcare disparities. In line with this goal, he currently is the PI on an academic-industrial partnership R01 grant entitled A New Technique to Make Gallium-68 Labeled Pharmaceuticals Widely Available for Clinical Use. He has been studying racial disparities in prostate cancer for many years. Dr. Osborne, Joe, thank you so much for joining me today.
And thank you very much for having me.
In your article in the Journal of Clinical Oncology from 2015, you discussed that Black men have a 2.5-fold increased risk of prostate cancer compared to white men. How much of this striking difference do you think is due to barriers to healthcare access, particularly access to advanced oncologic imaging such as PET?
Well, I think in the past there was actually it continues today, there is a really big gap in access to healthcare in general. And this was a big driver for this disparity, because what we have seen before is that there's this huge difference in mortality. But then we've looked a little bit more carefully in studies since, and we've seen that mortality difference really disappears once you look at clinical trial participants. So we looked at about 50,000 Black males who had been in clinical trials, and then that clinical trial data is saying once they have access to that level of care that you have in a clinical trial, some of these disparities actually go away. And it's important for imaging today because imaging has a much greater role in prostate cancer than it did 10 years ago. Before we would have bone scans here in service, CT scans, even MRIs when people were first diagnosed. But now we have PSMA scans, PSMA PET, which is likely to change the prognostic features of prostate cancer with advanced disease. And that's something that we do. And this is something that if there isn't broad access to this technology, we certainly won't help the disparity, but we can even make it worse, where patients can only get this great technology at tertiary care centers, and people who need it will not have it. And that's what the R1 is in part about, is broadening this access of these PSMA scans everywhere.
Absolutely. So in the clinical setting, it really seems like Black men and other populations of color are dramatically underrepresented when it comes to advanced imaging of castrate-resistant prostate cancer. And within clinical trials, just as you mentioned, this disparity appears to be lessened. What do you think we can do, or what do you do in your clinical practice to try and mitigate this in the clinical setting?
So we've done something very important here at this particular practice. And this is one of the reasons why I came to join the Cornell practice. We have an enterprise view where we have New York Presbyterian in Queens, New York Presbyterian, which is Brooklyn Methodist, and our chairman is going to cite the best technology for PET scanners that we have here at the institution at Brooklyn Methodist. If we are able to deliver and make gallium PSMA here and deliver it to the Queens site, to the Brooklyn Methodist site, all of a sudden you have the best technology available scanner-wise, the best radionuclide available radiochemistry-wise. And we could do this at Brooklyn Methodist in Queens, which had typically been at quite underserved areas. As we've seen here in New York City, even in a very small city of 15 square miles, the disparity can start after a mile and a half from Court Health.
Absolutely.
Right? What we see in Brooklyn is not what we see in the Upper East Side. And this practice is going to, with the lab,
really important effort, and I myself am very proud to be a part of this group.
So our chairman, Rob Min, and our dean, Augustine Choi. So they've sort of gotten together to, with the hospital, which is New York Presbyterian, to partner with Brooklyn Methodist and the chairman there to make sure that we're able to get the newest Siemens scanner there. So Ramid has been pushing this envelope for some time, and so we've got to find ways to bring ourselves, at least virtually, to Brooklyn Methodist with what we do in advanced imaging so that the patients can get it wherever they go in the New York tri-state area.
Absolutely. Thank you. And then my next question is, what do you see as future directions in racial disparities research in oncologic imaging? And how can imaging scientists, especially those of us early in their careers, learn more on this subject and get started?
Well, one of the important things we learned through the last couple of papers, this was with me and Dan Spratt, where we had a paper in JAM Oncology and JCO, is that many of the papers with castrate-resistant prostate cancer, as strange as it might seem, actually didn't categorize patients by race, by gender. They didn't have, well, gender's not important. They didn't have all the important features in the patients who they were serving. And so it became very difficult for us to even figure out what percentage of patients were African American in our trials, right? So it's not about just having the best technology at the scanner that's right around the corner from your office. And so if you do things for a particular hospital system, and you know that they're not taking care of Medicaid patients or other patients who have no insurance, you could actually drive the disparity unwittingly, even doing really good work. So part of it is yet another responsibility of making sure really good work ends up everywhere and with access to all.
Great. As far as junior radiologists, let's say a radiology resident listening to this podcast is getting really inspired by this, as I'm sure many will, what would be a good starting point for them to get involved in this type of research?
Well, I came to this conclusion sort of separate, once again, from our chairman, Robert Min, who very much believes that radiologists are physicians, right? We take care of patients.
Yes.
And so when we think of patients and their needs as if they're, family or they're someone we know, or if we are primary care physicians, you do so much better. Right. And so many of my papers early on with prostate cancer didn't really have that much imaging in it. And I started from the question of, well, why is the mortality rate 2.5 times what it is in the general population? And when you start as someone who's junior, you start looking at a question. I could see that there's something important here. And you're going after important things, which is exactly what you're doing with the meningiomas and the dotatate and a lot of the other, and the dementia. I mean, these are things that aren't going to be sorted out tomorrow. It's going to take a while. But being a part of that is actually really special. because you're sort of unlocking the puzzle that's actually quite big. It affects a lot of people, it affects a lot of families, and it's something that has to be figured out.
Absolutely. And you have certainly built a career that is inspiring on understanding prostate cancer and improving prostate cancer imaging. And as we've learned, access to prostate cancer imaging, which is so important. Thank you so much for this interview.
And thank you so much for spending the time with me. This is great.
Thank you. Dr. Randy Miles is Assistant Professor of Radiology at Massachusetts General Hospital. He received his Master of Public Health from Harvard and his MD from Mayo Clinic College of Medicine. Dr. Miles's clinical, research, and public health efforts have focused on reducing disparities in breast cancer mortality, primarily through identifying barriers to screening, creating patient-centered initiatives to improve access to breast imaging, as well as improving delivery of high-quality, evidence-based care for all patients. He also has applied his public health background to collaborate with and guide the breast imaging division at Jiahui Hospital in Shanghai, China, where he has implemented various initiatives to improve workflow and patient experience. Dr. Miles is also the PI on multiple funded grants, most recently the prestigious Association of University Radiologists General Electric Radiology Research Academic Fellowship Award, more commonly known as the AUR Giraffe Award, which he actually received this year. Congratulations. He has authored numerous publications and book chapters and has served on many local and national committees. Dr. Miles also shares his passion and scholarship in breast imaging with trainees at MGH in his role as Director of Breast Imaging Education and his leadership of a mentoring initiative. Dr. Miles, thank you so much for joining me today. You are a highly accomplished scholar in the field of racial disparities in breast cancer. In fact, we have never met, but every radiologist I talked to about this podcast idea has recommended you based on your expertise. I would love to hear what initially motivated you to get involved in this research area.
Sure. Thanks, Jana. I can still remember it like it was yesterday. My aunt, she picked me up from school. I was in the 5th grade. We arrived home, and that's when she broke the news to me that my grandmother, who I was really close with, had passed away. So my grandmother, she was 55 years old at the time. She was definitely someone who really prioritized family above all else, including her own needs. At the time, I didn't realize that she had recently been diagnosed with cancer, but I do remember just crying as my aunt hugged me and just remember feeling a sense of helplessness. This experience really stuck with me until I reached college. That's when I started to realize that 55 is not really that old. It's really when I started to think about some of the contributing factors, including socioeconomic status and location, that led to my grandmother's premature death. And I eventually came to the conclusion that if certain barriers were removed, then maybe her death could have been prevented. I also started to think that I didn't want another 9-year-old kid, or any kid for that matter, to have my same experience of losing a close family member prematurely when it could potentially have been prevented. So entering medical school at the Mayo Clinic, my primary goal was to reduce healthcare disparities in my career, which I felt had already impacted my life. As you mentioned before, during medical school, I also attended Harvard School of Public Health, and this is where I really explored breast cancer mortality disparities in African-American women specifically, and I focused my entire year of study on this topic. One of the most startling statistics that I learned during this year was that African-American women have a 42% higher breast cancer death rate compared to white women. And I really, following this year, just really wanted to be a part of the solution in improving this issue as a breast imager and researcher. Definitely since this time, my research interests have definitely grown to include other topics, including improving care for women from other traditionally underserved backgrounds. Overall, my clinical, research, and public health goals are definitely to elevate the level of care for all women, but I am particularly focused on ensuring that we do not leave anyone behind in this aim.
I'm speechless, and thank you so much for sharing your personal story, which I can very much empathize with, having lost my grandmother as well. Sorry.
Thank you.
It's really heartbreaking to see these statistics. We all are, as physicians, aware that racial disparities exist, but these numbers you just mentioned are just really heartbreaking and show how important work of researchers like yourself is to improve the current situation. And you have really built a successful career on this already For example, at MGH, you have worked to identify numerous barriers to breast care and address them directly. Most notably, your work has led to the implementation of a same-day biopsy program for women receiving a breast biopsy recommendation. Could you tell me more about how this program has reduced previously existing disparities and thereby improved outcomes?
Definitely. First, I'd like to say the MGH same-day biopsy program has really been a team effort by all of the breast imagers in our section who have worked to make this program a success with tremendous leadership from our section chief, Connie Lehman. Same-day care is probably one of the most important tools we can use to reduce health disparities. If you think about it, in most cases, a woman starts off her breast imaging experience with a screening mammogram. If there's a suspicious finding on her exam, then she returns another day for a diagnostic examination where she receives additional imaging. If the finding is still deemed suspicious after her diagnostic examination, then she returns again for a biopsy. So that's typically 3 separate visits to the breast imaging suite for each of these steps. And those represent 3 different occasions where a woman could be lost to follow up. Unfortunately, as breast imagers, we have all seen these cases when a woman arrives in our clinic with an advanced cancer after missing her routine screening examination, or, she's lost to follow up because she didn't finish her prior workup after a suspicious finding has already been identified. These are definitely the worst days of my job, and I'm pretty sure the worst days of my colleagues in the field when we see these cases. Same-day care, where we perform these exams on the same day, really help to prevent these occurrences, especially among women who may face additional barriers to receiving care that may be related to health literacy, socioeconomic status, and transportation issues. It also eliminates some of the stress and anxiety associated with anticipation of the next exam. So our group, we implemented a same-day biopsy program a few years ago, meaning we perform the biopsy on the same day as the biopsy recommendation following a diagnostic exam. We reported our experiences pre and post implementation in a paper led by Brian Donchos. And what our study revealed was that mean time from examination to biopsy decreased from 9.6 days to 3.6 days following implementation of our program. One of the kind of most remarkable statistics is that prior to our implementation of this program, we saw that non-white patients waited on average 2.3 days longer than white patients to receive a biopsy. After we implemented this program, there was no significant difference in biopsy wait times between non-white and white patients. We also saw that we had a jump in patients actually receiving a biopsy on the same day, jumped from 11% to 51%. Our program has really demonstrated the true importance of same-day care and how combining care opportunities could directly reduce disparities, especially those seen in traditionally underserved backgrounds.
Absolutely. And this is so important. And not being a breast imager myself, I do know that here at Cornell, a similar program has been implemented as well. And I think hopefully more and more, especially academic centers across the country, can implement similar programs to improve access to care. So this is wonderful.
Definitely.
When it comes to screening, breast cancer screening, different guidelines exist. For example, and I know it's a very controversial topic, but for example, the USPTF guidelines recommend biannual screening starting at 50, an approach that can exacerbate existing racial disparities, seeing that breast cancer diagnoses peak for Black, Hispanic, and Asian women in their 40s. This is in stark contrast with ACR guidelines, which call for annual screening starting at age 40. What can we as the radiology community do to advocate for our patients?
Great question. We can do a lot to advocate for our patients. I'll focus on some of the more critical elements. I'm all about direct messaging to our patients and providing them necessary information that they can take back and talk to their primary care doctors. I think the first thing that we can do, and something that breast imagers can do today, is to make sure that you actually take the time to talk to patients. As radiologists, we are often in dark rooms by ourselves, and we can, typically complete many of our clinical duties without talking to a single patient all day. This can actually occur in breast imaging as well, especially when you're working with a sonographer. So I definitely just recommend taking additional time to go into that ultrasound room, even if it's a negative case, and make sure patients don't have additional questions or issues that, they would like addressed. More broadly, I think we need more breast radiologists in the community, giving talks at churches, community centers, hair salons, about the importance of screening, especially in traditionally underserved communities. In this COVID era, we do have to think of more innovative ways to reach large groups, including, using platforms such as Zoom or other popular social media programs to get the word out about screening.
I think that's a really interesting idea you just mentioned about going into the community yourself as a breast imager and giving these talks, either physically in churches or other places where people congregate, or now with COVID, as you mentioned, virtually. Have you yourself had an experience like that, and what was that like?
The Society of Breast Imaging has started a lecture series for patients where they can ask questions directly to breast imagers about screening and issues related to screening. And I think it's really been helpful, so that patients don't have to wait for their next, primary care appointment to ask these burning questions. And it encourages them to talk to their primary care doctor about these issues.
It's amazing. So you're really making the patient more equipped to ask the right questions when they go to see their PCP. That's great.
Exactly.
You mentioned COVID earlier. Do you think that delays in screening related to the COVID-19 pandemic will further exacerbate existing racial disparities in breast cancer diagnoses? And if that's the case, what can we do today to address this issue?
Definitely. There's a lot we can do to address this issue, preventing exacerbation of existing racial disparities in care. Our group at MGH has committed to providing same-day care during the COVID period, and we have really worked hard to continue this practice thus far as we transition to this new normal. Let's reimagine how we have traditionally practiced breast imaging. Let's reimagine where a woman always leaves the breast imaging suite with her results, where a woman does not have to take an additional day off work or find someone to keep her kids just to return to our clinic on another day for an additional examination or biopsy. A workflow that leads to women coming in, receiving all of their breast care on the same day has so many benefits, while improving the overall patient experience. In addition, this will, particularly help women from traditionally underserved backgrounds who may experience additional barriers to care, as we've discussed before, and could reduce the chance that we lose some of these women to follow up. So last week on service, I read a screening examination in the morning. Within 5 minutes of it being completed, my colleague completed her diagnostic examination in the next hour. At that point, he recommended a biopsy. She was able to have that biopsy by the end of the morning, which eventually revealed invasive ductal carcinoma. I'll add as well that this was at one of our sites that sees a large percentage of traditionally underserved women. But this patient received her full breast imaging workup, including biopsy, in one day, and was extremely grateful. But it's an example of how we are aiming to transform care in MGH by really focusing on reducing time to diagnosis, decreasing patient anxiety about the next examination, and limiting loss to follow-up.
Thank you for this example. Dr. Randy Miles, it's been a pleasure talking with you. I've learned so much, and you're truly an inspiration. And I hope that many of our listeners, especially our more junior residents and fellows, will consider emulating your career in reducing racial disparities in imaging. Thank you so much.
Thank you.
Dr. Ashley Prosper is Assistant Professor of Clinical Radiology at University of California at Los Angeles. She specializes in cardiothoracic imaging and has dual board certification from the ABR and ABNM. Dr. Prosper serves as the co-director of the lung cancer screening program at UCLA. As a member of the American College of Radiology's Data Science Institute, she contributes to the guidance of artificial intelligence efforts as they pertain to thoracic imaging. Dr. Prosper is also co-chair of the University of California's Appropriate Imaging Coalition Task Force on Pulmonary Embolism. Her research efforts are focused on early detection of lung cancer, among other topics, and she has been the PI or co-investigator on multiple funded grants. She also is the chair of the Committee on Diversity and Inclusion of the California Radiological Society. Dr. Prosper has been the recipient of numerous awards and honors, including the Outstanding Young Faculty Award for the past 2 years in a row. I was very impressed by the multiple years in a row. Very, very cool.
Thank you.
Congratulations. Dr. Prosper is part of the Academy for Radiology SESI class of 2020-2021, which is how we had the pleasure of meeting, virtually, of course. She has recently been awarded a grant to study racial disparities in lung cancer screening. Dr. Ashley Prosper, wonderful to have you on.
Thanks so much for having me.
Thank you for being with us. So in a recent commentary article in the journal Cancer from this year, you point out that African American men are 37% more likely than white men to develop lung cancer and have overall higher morbidity and mortality, although their overall exposure to cigarette smoke is lower, according to the American Lung Association. How can lung cancer screening programs, such as the one you co-direct at UCLA, ensure that these racial disparities are adequately addressed?
Excellent question. The numbers that you just highlighted, the fact that African American men have a 37% higher rate of developing lung cancer as opposed to their white counterparts, despite smoking less, tells us that we have a lot of work to do. What we also know is that the sub-analysis of data from the National Lung Cancer Screening Trial, which was the largest lung cancer screening trial to prove that low-dose CT reduces mortality from lung cancer by about 20% as opposed to chest X-ray screening. When we look at the data for African-American patients who were enrolled in that trial, we see that while they entered the program or the trial with the highest level of risk of both lung cancer mortality and all-cause mortality, through participation in lung cancer screening, they had the greatest degree of benefit, so the greatest reduction in both lung cancer mortality and all-cause mortality. So that tells me that we have both an incredible challenge and an incredible opportunity. So we have a tool that's proven to reduce lung cancer mortality that I feel compelled to make sure is given to patients who need it most. So what I do when I look at our enrollment data here at UCLA is I'm very cognizant of the fact that my screening enrollment should mirror my patient population in the health system. And, I'm happy to report that to date, we've kept in line with our demographic data for the health system in general. So we always have room. Oh, thank you. We always have work to do in terms of making sure that more patients who qualify for lung cancer screening get lung cancer screening. I mean, across all racial and socioeconomic data, when you look at the number of patients who are utilizing lung cancer screening, it's a small portion of those that are eligible. Studies range anywhere from about 5 to 12%. So overall, we have a lot of work to do in terms of increasing engagement and utilization of screening. But particularly for African American men who have such a great risk, I want to make sure that if they do meet criteria at this point, we have to make sure that they have access and ability to receive screening.
Absolutely. And this is so important. And it really parallels, I've had the pleasure of talking to my division chief, Joe Osborne, about prostate cancer, and to Randy Miles about breast cancer. And there's really a similar theme emerging where the key issue is access and improving access. So congratulations on this important work. I would love to hear, once lung cancer is diagnosed, have you found that there are similar racial disparities on kind of the diagnostic management side, and how can those be addressed?
When I was thinking about this question, two thoughts came to mind. One is, one of the beautiful things about radiology is once we get a CT and, we're looking through the lungs, everyone is equalized, right? So no matter where you come from, what your racial or ethnic background is, we're all basically reduced to Hounsfield units on a CT. Yeah. So as radiologists, when we're reading these, exactly, we really, as radiologists, we get down to the basics, and we see everyone as, having the same core essence. One of the challenges that I think we face in lung cancer screening, detection, and care is that right now, we are obligated to follow the United States, Preventative Task Force screening criteria. And what we know is that by using these criteria, we're not capturing all of the at-risk patients that we possibly could. So I'm going to give you an example. There was a Southern Community Cohort study that was assessing the efficacy of the current guidelines to figure out, who's eligible for lung cancer screening. And, this was a really large study. There were about 48,000 ever smokers, including in this cohort, and 67% of them were African American. What was really troublesome is only a third of the African American patients who developed lung cancer within that cohort over a 12-year period were eligible for lung cancer screening by the USPSTF criteria.
Oh, that's terrible.
Now, if you look at the Caucasian patients who were part of this cohort, greater than 50% of those who developed lung cancer would have been eligible by the current criteria.
Does this have to do with age of onset, or what is the...
It does. So what we know is that for whatever reason, and we haven't quite figured this out as a scientific community yet, African Americans develop lung cancer at lower pack year smoking histories and at younger age. So our current guidelines are not capturing all of the African American patients at an early stage. So I think one of the big challenges to making sure that all patients have the best chance at getting cancers caught at early treatable stages and improving outcomes is going to mean taking another look at the eligibility criteria. I'm really optimistic and hopeful because I know that, USPSTF is currently undergoing a review, and a lot of people have pushed to, sort of open up those criteria to make sure that we're catching these vulnerable patients earlier. And that's my biggest concern right now.
That's so important. I'm curious to hear more about your research and how you got involved in racial disparities research, which is obviously a very important field as it applies to radiology. So how did you get started, and what are some research questions you're currently asking?
Thank you. When I started getting involved with lung cancer screening and co-directing our program here at UCLA, I was really honestly shocked when I saw the numbers across racial and ethnic groups and seeing just how high the incidence rate, morbidity, and mortality is for lung cancer in African Americans, and particularly African American men. And I just felt this obligation as an African American female physician to say, I have the education, the knowledge, the tools, the resources to try to reduce disparities in this particular field, because this is one that I operate in. This is one that I work in and day out. So while there are a plethora, unfortunately, of racial and ethnic disparities in healthcare, this is one that I am fortunately equipped to work in this space. So the American College of Radiology, they announced an innovation fund grant to sort of empower, researchers to do pilot projects to improve patient and family focused care. So my particular goals in this project are to make sure that the outreach and the educational and informational tools about lung cancer screening are well received and applicable to the African American patient population. And I'm focused on making videos and handouts and scripts that are culturally competent and relevant. And a big component of this is working closely with a panel of community stakeholders, because I recognize that while I am, African American myself, I am not enough of a voice to say I can speak for all. I recognize that I am sort of an academic bubble, and I want to make sure that I hear from a variety of voices. And the deliverables at the end of this year-long work are to have not only the videos, the educational tools, the pamphlets, but also a guidebook on how to form these community partnerships. Because ideally, I want this to be something that can be done for lung cancer screening programs across the country who are interested in partnering
That's really wonderful. So those in our audience who are listening and are inspired, as I'm sure everyone is, I know I'm inspired and I'm a neurobiologist.
Oh, thank you.
So I'm sure many people might be listening and thinking to themselves, I would love to implement something similar at my institution. So I will be very liberally handing out your email.
Oh, thank you.
So to anyone who's listening, or, they can follow you on Twitter, obviously. And
definitely.
I think this is something that's a truly wonderful effort and should be emulated by everyone who's able to. So congratulations on that. And
thank you so
hopefully,
much.
This will get you started also on a trajectory to NIH funding.
Exactly.
I'm excited to hear more about under the auspices of the Academy for Radiology SESI program.
Yes, definitely. I have to say that it's been such a joy to be able to share our experiences as we apply for all of our grants. I think something that is really valuable about this is this peer-to-peer support.
Absolutely.
Submitting my first grant early last month, there's so many questions. You fill out all the forms, you have a project that you feel excited about, and then you think, who can I talk to about this? And it's been so nice to, share those fears and hopes and, disappointments and all those emotions with my fellow junior faculty. So
yeah, I felt the same way.
Thank you for that.
Oh, yes. Thank you. So actually kind of staying on this topic, as you're building your research career in this field, what has your experience been with regard to adequate mentorship, support of your professional growth, access to research funding?
I have to say that I'm really grateful to have found an academic home at UCLA. It's been really an incredible journey. So I'll tell you a little bit about how I ended up here. I was at a National Medical Association meeting. The NMA is an organization that was formed really to support underrepresented minorities in medicine. And I was giving a lecture, and someone stood up in the audience and asked me a question. And that turned out to be my future section chief. So Dr. Kathy Brown was in the audience. We met each other. We stayed in touch. She told me about an opening at UCLA, which I subsequently applied and interviewed for. And I'm so glad to have met her at that conference and to have ended up here at UCLA. In addition to having her, she's a master educator, award-winning teacher. She's also the Associate Vice Dean for Equity, Diversity, and Inclusion here at UCLA. Wow. So she's been so helpful in terms of helping me to structure my lectures, my teaching style, and to, also work on this Innovation Fund grant. Another person who I met here at UCLA is Dr. Denny Aberle. She actually was the principal investigator of the National Lung Cancer Screening Trial. So she is the person who, really forged ahead and ran this huge clinical trial to prove that low-dose lung cancer screening is effective in reducing lung cancer mortality. And she has been incredibly generous with her time. We meet at least once a week, if not more often. She's mentored me on, my own grant applications, has held my hand as I've applied for my first NIH grant. And
that's so important.
Oh gosh, yeah. It takes a lot of people to support a junior investigator.
Yeah.
And then, I could stay on here for the whole podcast talking about the people who've helped me, but the other key component for me has been my chairman, Dieter Ensman, and I email him all the time, asking him to sign off on, grant applications or programs supporting leadership development or research development. And to date, he's always said yes. He's been supportive and he has, allowed me to pursue these things. So I feel supported and empowered, and the main thing is just following through and living up to the support of all these great people.
I think that's wonderful. Honestly, having met you and learned about all the great work you do, I think they're lucky to have you at UCLA.
Oh, thank you.
Thank you so much for sharing your experience and knowledge with us today, and look forward to speaking with you again soon.
Yes, and maybe someday in person. It would be.
Take care. Thank you.
Take care. Thank you.
This concludes my inaugural podcast episode for Radiology Imaging Cancer. I learned so much from our guests today and was inspired to do more to actively work on decreasing racial disparities in oncologic imaging. Key takeaways from Drs. Flores, Osborne, Miles, and Prosper were improving access to screening as well as to advanced imaging after diagnosis, decreasing barriers to care in the form of establishing same-day biopsies and following up with patients in their native language where applicable, as well as striving to provide culturally competent cancer care and always remembering that every imaging study is a patient encounter. Above all, I think it is important to acknowledge that the root cause of these aforementioned problems can be traced back to racism, including structural and institutional racism. To successfully address healthcare disparities in oncologic imaging and oncologic care, we must do the work to be actively anti-racist and support our Black colleagues and patients and communities of color more broadly. Thank you so much for listening. I hope that you enjoyed this episode. We would love your feedback. Please subscribe on Apple Podcasts or wherever you get your podcasts and give us a rating to help more people discover our show. I'm Dr. Jana Ivanidze, and this is Radiology Imaging Cancer. See you next month when we will talk about global initiatives in oncologic imaging and radiation oncology.